Hey everyone, and thank you for joining us tonight. We have a lot of great scientific content to get into, but real quick before we start, use the questions box on the lower right-hand side of your screen if there's anything you want to ask. We'll have some time to go over some of those questions at the end, and if we don't get to your question, we'll make sure we reply via email this week and get back to you. So let's get started here. I'd like to introduce Dr. Kim Cooch, CEO and founder of Caries. Dr. Cooch has successfully been practicing dentistry for 35 years, still practices here 3 days a week in Albany, Oregon, and he's the leading authority in ATP as it relates to caries risk assessment and cariology. We have a lot to get through, so I will let you take it away from here, Dr. Cooch.
Hey, thank you, Cody, and welcome everybody tonight. We've got a huge crowd, and this is my favorite webinar of the year, and I know that it seems to be real popular with you all as well. So it's kind of an interesting year in science and dental caries in the last year. I picked out a couple of hundred studies, weeded it down to 100, continue to prune it down to about 50, and that I think are kind of interesting. I found interesting, and I think that continue just to broaden our knowledge of this disease as we try and treat it. So I want to go through those with you tonight. I've kind of tried to break them up into a logical sequence so that hopefully this makes sense to you. One of the things I've been teaching now for the last, probably 6 or 7 years is to really start looking at the usual suspects. When you sit down with a patient, there's real patterns for this disease, and being able to identify and quickly identify what the patterns that are affecting or the risk factors that are affecting your patient individually and being able to address those with them makes this process just a lot less complicated for us and for the patient as well. And based on our own data, you've seen this before, but by survey, the #1 risk factor self-reported in about 13,000 patients in our database now is saliva. 63% of them report having a dry mouth. Typically that's from medication use or age. 55% admitted that they either eat sugar too frequently or they eat too much sugar during the day, and certainly sugar-sweetened beverages are a huge issue here in the United States. Third on that list of our suspects is bacteria, and they either have too much bacteria or they've got the wrong bacteria or bacteria behaving badly in their mouth. And of course the newcomer to this has been genetics. There's been a lot of research on genetics in the last 7 years. But at the end of the day, this disease is about pH, and it's all about trying to maintain a healthy balance in the mouth in regards to pH. So I kind of broke these down into, tonight, the studies into groups. The first one we're going to look at is saliva. There weren't a particularly large number of studies about saliva as it relates to dental caries, but when you look at these mouths, these patients have a dry mouth. Their teeth are dry. Sometimes you have to pry their cheeks off of their teeth, and there's not bubbles of saliva in their mouth. So when you see a patient like this, I mean, you know that this is 63% of the time patients have a dry mouth or self-reporting a dry mouth. So, I mean, if you just think saliva, diet, and bacteria, I mean, I always ask first, do you feel like you have a dry mouth? Because that's the most usual suspect, right? I mean, when a woman is battered or beaten and killed, it's, 87% of the time it's the husband. I mean, start there. Start with the obvious stuff. So this was a study that was published this last year, just in December. It was a survey of adults, 2,110 Japanese adults that had 10 or more teeth, and they were looking at salivary flow rates and then their risk factor for dental caries and also periodontal disease. So I thought this was kind of interesting. Now, the interesting part when I started reading this study is that they were looking at odds ratios between their salivary flow rate and their risk for both periodontal disease and dental caries, and they started at 3.5 mils per minute, and had the highest odds ratio, and I'm thinking to myself, this is ludicrous. I mean, we look at 0.7 mils per minute or 1 mil per minute, but as you get into the paper, they actually started with the standardized flow of 1 milliliter per minute, which is pretty normal salivary flow. 3.5 is a lot of saliva, but the odds ratios is the further they got with more saliva, the less risk, dramatically less risk they had for periodontal disease and dental caries. So having a drier mouth, certainly, so this was modeled and looked at regression analysis, and it was done with a salivary rate basically of, starting at a starting point of 1.0 mil per minute, and then they were looking at odds ratios. So the conclusion of the study is dry mouth affects your risk for both dental caries, which we've already known. There's a lot of research on that, but also periodontal disease as well. This study was published this last year as well in December, and I thought this was pretty interesting because we see this from time to time. You get these young kids that come in and they have these black stains, superficial black stains on their teeth. I'll have moms will always ask me, what causes that? Well, think about well water, vitamins, and you throw your hand in the air. And there's been some research most recently that the predominance of black stains was correlated to a high level of actinomyces in the mouth and a low salivary prevalence of S. mutans and lactobacillus. And so these patients typically don't have any tooth decay because they have low levels of those bacteria, but do have high levels of actinomycetes, and that may actually be a causative risk factor for this. So it's a matter of just having high levels of those bacteria in the mouth in these kids, so it's a bacterial origin. So it doesn't seem to be any other serious effects from it, but at least gives you a bit of information. If you see this and a parent asks you about it, you've got an answer for it, or you refer back to this webinar and remember that. So actinomyces and black stain. When we look at diet, again, we're really talking about frequency of sugar and total intake of sugar. And again, when you see that pattern of disease, when you see a person typically has a dietary problem, the pattern of decay is spread kind of everywhere. It's just all throughout the mouth, all different random surfaces, but it's everywhere. And so that's a pattern that you should look for. This was a paper, the higher sugar consumption along the life course, the higher the dental caries increment. Even low levels of sugar consumption was related to dental caries despite the use of fluoride. And this was came out of Brazil, this study. They looked at these kids, about 359 kids in a cohort, at age 6, at age 12, and at age 18 to do their DMFT scores. And then they looked at their sugar behaviors and diet at ages 4, 15, and 18. So they looked this over a period of 12 years, or actually 14 years, looked at their dietary habits, and then looked at their decay rate. And it's just as you would expect, the higher the sugar consumption, the higher their decay rate. But even low levels of sugar still had an increased risk for dental caries, and despite the fact that these kids were using fluoride. So, that just reinforces what we know. Here's another study. This came out of Puerto Rico. 1,587 12-year-olds. They did a 24-hour diet survey on these kids, and after adjusting for all the other risk factors, total carbohydrates and sugars, more than 10% of their total daily intake of energy dramatically or significantly increased their caries risk potential. So I think as we look at the World Health Organization recommendations for sugar intake, they've recommended that it should certainly be less than 10%, ideally less than 5%, and in a real ideal world, we would be eating less than 3% of our caloric intake per day from sugar. The problem we've got in America is, the average American eats 23 teaspoons of sugar per day, and to get down to that, 3% load would take us down to about 2/3 of 1 teaspoon. So we have a huge sugar burden here in the United States, and that's why we're seeing a lot of the decay that we're seeing, but also creates a huge challenge for us on how do you fix that. So sugar more than 10% of their caloric intake every day significantly increases their risk of dental caries. This is a cross-sectional study, and it's looking at frequency of sugar-sweetened beverages, and then looking at how that correlated to tooth loss. And this was a survey, a study of 22,526 adults from age 8 to 39, and they looked at particularly at tooth loss. And so increased intake of sugar-sweetened beverages increased the risk of tooth loss for these young adults. So that's, again, that's an issue, and a lot of that is, tooth loss as a result of dental caries in this group, not periodontal disease. So again, sugar-sweetened beverages are an issue, and we've known that. This came out of Mexico, 417 adolescents, and published in JADA back in February of last year. And we know that sugar-sweetened beverages are also associated with erosive tooth wear, mainly on the mandibular first molars, but it also, that erosion was associated with age and also xerostomia. But again, we're talking about sugar-sweetened beverages, so that's been an issue. This study came out of India, and it was 433 2- to 6-year-olds, and they looked at their body mass index. And what I found interesting in this study is we've had a number of studies that have been published in the last probably 10 years looking at an increase of dental caries risk with a higher body mass index. So obese children tend to, eat more sweets. That's a generalization, but the children that are obese tend to have more carbohydrate intake in their diet, and so we've got a number of studies correlating high body mass index to high caries risk. What was interesting in this study was that the malnourished kids, the kids would have lower than normal body mass index, also had an increased risk for dental caries. It was just the kids in the normal range of BMI that had the least amount of risk for dental caries, and so it could be that the dietary habits of the kids that are malnourished certainly may have increased sugar or carbohydrate intake, and that may be their only source of food for the day. But I thought it was interesting that not only does the high body mass index increase the risk for dental caries, but so does the low body mass index. So that's just another data point that I thought you would find interesting. And again, another study, this was mothers and children, 40 children that had early childhood caries. They were from 3 to 6 years old, and then they compared that to 40 children and mother pairs that were free of decay. And the children developing early childhood caries have a diet characterized by high free sugars, and consumption of drinks, particularly containing free sugars, is the most important factor, and there's a relationship between the mother's oral health and DMFT scores and the children of early childhood caries. So this just reinforces a lot of research that we've had in the past. We know that the mother has a profound, or the primary caregiver has a profound influence on the caries experience in the child. So, that's a good reason for us to have these conversations with the parents as well. So the biggest risk for the kid appears to be, literally almost appears to be mom. Then I get a lot of questions on this, and so I included this. This was a really good paper on this. Came out in the Evidence-Based Dentistry Journal back in September. But I have a lot of people, a lot of moms particularly ask me, and a lot of dentists ask me, does nursing, breastfeeding, does that increase the risk for dental caries? And if you stop and think about this for a second, I always say no, because, that's how nature worked this out, right? And nature didn't create a system to give us dental caries. So the reality is, breastfeeding does not increase your risk for dental caries in the child. And this was a systematic review of 63 papers worldwide. However, the interesting thing about this was children that were breastfed beyond 12 months, a time period when more primary teeth are erupting, had an increased risk of dental caries. Up to 12 months, breastfeeding had no risk whatsoever, but beyond 12 months, it seemed to increase the risk. And I know that most, I think, American moms don't really breastfeed much past about 6 months, and then they may continue to pump for 6 months, another 6 months. The challenge becomes when you start bottle feeding the child, even putting breast milk in the bottle. If this child goes to bed with a bottle and they have the bottle access to it for like 3 or 4 hours, you have those prolonged periods with that sugar in the mouth. That's when it gets to be a problem. Or they substitute, putting other sugar-sweetened beverages. Like I've even run into young mothers that were putting Coca-Cola in the bottle and giving it to the kid to go down with. So, those are this is what people do. Human beings are complicated. We are complex, and we see these kind of things. They don't know any different. They don't know better. So it's our job to really help educate them. But for all of the people that have this question about breastfeeding, again, it up to 12 months does not have any risk whatsoever on dental caries. And then I included this because I thought it was interesting. This looked at the evidence on the recommendations that are given to us by our government and our, medical organizations on dietary sugars. And the basis of this was in the last 20 years looking at these recommendations, 9 guidelines and 12 different recommendations. And the bottom line was they don't meet the criteria for trustworthy recommendations, and they're based on low quality evidence. And so, you know, one of the challenges we have, I mean, you know, Michelle Obama, bless her heart, you know, took the food pyramid and they turned it into a circle. I mean, that's always our first response, is to do something like that. That doesn't change behavior. I mean, we really need to get to an emotional level and help people understand, and the recommendations we're giving are based on low-level evidence. So, you know, our profession's response to the caries issue, the epidemic that we have right at the moment, was to create ICDOS. We created a new caries classification system, as if somehow that was going to, you know, solve this problem. I mean, it's great. We've got better diagnostic criteria now, and we can classify lesions in, you know, 7, you know, different categories, and that's all well and good. The problem is, the problem relates back to the risks that are causing this disease, and we need to start focusing and addressing those risks. So, and I wonder even if if maybe the sugar lobby even funded this study, you know, looking at these recommendations, you know. So there's a lot of that happens in politics and in our government as well. This was, I thought, a very interesting study, because this is starting to happen in the United States. I know it's happened. I think it's in New Jersey that implemented the first tax on sugar-sweetened beverages, and I think they only taxed it at 3%. But this was a model study on adults in Germany, and they ran a modeling analysis from adults aged 14 to 79 over a 10-year period of time with a 20% sales tax on a sugar-sweetened beverage. And it was pretty significantly reduce the amount of caries incidence in the population based on taxing it, and it also would reduce treatment costs over that 10-year period as well. And it seemed to be that it would especially influence young, low-income males. They couldn't afford, you know, these drinks when you've got a 20% sales tax on them, and so that would, you know, they would probably be get the most benefit out of doing that. Now, I'm not advocating doing that. I just think it's interesting, because this is it's probably, we're going to see more of this, and it's going to be a pretty hotly contested topic. I know they tried in New York City, they tried to limit the sale of soft drinks to 20 ounces or less, and it's an issue. And I don't know what the answer is, but certainly it's an issue, and we could put a sales tax on it and maybe reduce some of our risk with it. Then when we look at studies that have come out on bacteria, there's been a lot of work in the last year identifying new bacterial species that play a role, and even Candida albicans that play a role in dental caries. So I wanted to share a bunch of those studies with you too. So looking at bacteria, when we look at bacteria, typically those patients have too much plaque on their teeth, or they may have a thin biofilm, but they've got a real active biofilm, and so you see a lot of decay. But typically this is a home care habit, you know, more often than not. You know, they've just got too much accumulation of biofilm on their teeth. So this was a paper that came out in Caries Research back in October, and what they found, they looked at both the inside of active carious lesions and then looked on sound surfaces. And so the thing that they found was that the most bacterial activity, and I got pretty excited when I saw the headline or the title for this paper, because I thought bacterial activity. I immediately thought ATP, and I got all excited, and then found out they weren't referring to the actual activity of the bacteria. They're actually referring to the growth and population, the numbers of those bacteria that were present. So what they found in the inside of the active caries lesion was that the highest activity, or the highest, you know, preponderance of bacteria were lactobacilli, and that's not surprising. I mean, we have other studies that indicate that as well. Whereas on the sound surfaces, smooth surfaces, where there was no caries activity, the highest number of bacteria were fusobacteria, the asaccharidic fusobacteria. So I thought this was a pretty interesting study. You know, again, identifying a new commensal bacteria for smooth surfaces, healthy surfaces, and could potentially be a studies suggest different activity patterns for, you know, lesions and smooth surfaces, and of course we would expect that. And then this was a study that was published this last year, and 140 children from Thailand from age 2 to 6, 68 of them had severe early childhood caries, and 72 of them were caries-free. And what they found was that the relationship, the ratio between strep sanguinus and strep mutans initially, and the amount of overnight plaque, other risk factors were low family income and bottle feeding, strongly associated with severe early childhood caries. So having a low number of strep sanguinus and high numbers of strep mutans in their initial ratio, and looking at their overnight plaque, and then again, low income and bottle feeding. And again, those, the bottle feeding were either prolonged periods with breast milk, but it's certainly at age 2 to 6, we're starting to look at formulas, and then probably other milk and or sugar-sweetened beverages. So that becomes a challenge. But looking at the ratio again between strep sanguinus and strep mutans. This was a study published this last year that looked at, took 28 11 to 12-year-olds, 18 of them had high caries risk, and 10 of them were caries-free. And what they found was that the salivary abiotrophia defectiva and actinomyces mariae and odontolyticus are associated with caries occurrence in MS-positive children with mixed dentition. So children that had high caries rate and had high levels of mutant streptococci had high levels of abiotrophia and actinomyces in their saliva. Interestingly enough, the children that were caries-free had high levels of Shuttleworthia satellas, and that was negatively correlated with the caries severity. So it could be that we've got a couple of additional bacteria looking at in the saliva, 3 additional bacteria there, and then looking at a new commensal bacteria as well. So, but abiotrophia and actinomyces, we've certainly implicated them in dental caries before. This study came out of China. It was a case report of 3 adults, and they looked at this particular case, and they found that compared to samples collected from a healthy individual and 2 patients that had rampant caries, the patients that have rampant caries have decreased bacterial diversity. There's fewer bacteria that can survive in that low pH environment. And then there was an increase in this healthy patient of leptotrichia, and that was detected by PCR and gel sequencing. So again, we're looking at less bacterial diversity, and then more leptotrichia in the patient that was healthy. So there's again another commensal bacteria there. And then we come to this one, and again, the same thing, a leptotrichia. Again, this was in children, 3 to 4-year-old children. 20 of them were caries affected and 20 were caries free. The relative abundance of Raphia dentacariosa and actinomyces, Vianella, Prevotella, salivae, and strep mutans were higher in the caries affected group. And again, we go back to Fusobacterium and leptotrichia were more abundant in the caries-free children. So we're starting to get a look at, salivary counts such as, the Raphia dentacariosa, which we've known for a long time as a predominant player in dental caries. But the Fusobacterium and even the leptotrichia may be useful for screening kids at some point in the future in terms of their risk for developing dental caries. So not only are we looking at identifying or reinforcing the studies we have on the pathogens, we're also starting to begin to identify patterns on bacteria that are associated with health. And so, that may give us an opportunity to look at some of those bacteria if it becomes more practical, clinically, to be able to do checkerboarding and what have you, in a short period of time or chairside to identify those kind of species. This was a study that looked at 19 young adults, and 10 of them had high caries rates and 9 of them were caries free. And then they looked at 139 caries-free adults from the age of 40 to 59. And what they found was that there was an association between Porphyromonas pasteuri and lower susceptibility to dental caries. So again, one more healthy bacteria, if you would, and even identified it was at a good enough statistical analysis that it may be a bacterial species that could potentially be used as a marker for maintaining, a healthy oral microbe against, dental caries. So Porphyromonas pasteuri. One more on the good team. This was a study of 75 adults from age 20 to 70, and looking at strep mucan levels in both healthy versus gingivitis and chronic periodontitis. So this is an interesting study from the standpoint. Typically, we just associate high levels of strep mutans with dental caries, but what they saw was there was a positive correlation here with periodontal parameters as well. And their conclusion was more severe forms of periodontal disease may actually create these little ecological, micro environments that aid in the proliferation of strep mutans as well. So strep mutans was, had a high correlation not only to dental caries but also periodontal disease as well. And so this is one of the first studies that I've seen that actually asked that question or examined that, and I thought that was interesting. Now, we talked a lot kind of in the past about Candida albicans, and there have been a number of studies here on Candida and dental caries I want to share with you right now. We've known for a long time that Candida albicans plays a role in dental caries, and Candida is also extremely acid uric. And so this is a really important thing to note. Like, I'll have doctors ask me, like, what do I do to try? I've got patients that have candidiasis, and I've tried all of these things, and Nystat, and I've tried all this. What do I do for these patients? Don't seem to be making a lot of progress. Well, understanding the fact that Candida is strongly acid uric, they're adapted for an acidic environment. So raise the pH. Raise the pH in the mouth. So, anecdotally, I can share with you that I've used a rinse that had sodium hypochlorite in it. The carie-free CTX4 treatment rinse, and had very good results at eradicating Candida using that, just because they're not adapted to be able to survive in a high pH environment. So that's just a logical thing. So this was a study that looked at 61 2 to 5-year-olds. Instead of using a DMFT score, they used IC-DOS, and the prevalence and the carriage rate of Candida non-albicans in the saliva of these preschool children correlated strongly to their caries experience. So when they talk about a caries rate, they're just talking about they've got a lot of that organism. So high levels of Candida albicans and also Candida dublianensis. And so the dublianensis is been implicated a couple of years ago. It's difficult to identify them when you're doing checkerboarding, differentiate between Candida albicans, and there's a lot of false positives on that. But Candida dublianensis has been implicated now as well as a pathogen for dental caries. So in this study, again, this is a study published 26 caries-free children and 26 children that high caries risk, and found that there's a high level of Candida dublianensis in the caries-active children, and it could have been underestimated, due to the difficulty of trying to distinguish between these two bacterial species, or these two yeast species. So, again, this is an organism that I think we're adding, pretty solidly adding to the list of bad guys. And then on top of that, we have yet one more. And in this study, they took plaque samples from caries-free and high caries risk children, and then they inoculated them with Candida species. They inoculated them with Candida albicans and parapsilosis, and found that the ones that had both of those, that they had inoculated into the biofilms, and then looked at their demineralization potential on bovine blocks. The highest block demineralization occurred when both of those two Candida species were present. So the parapsilosis can be added to albicans and dublianensis. So we've got 3 species now of Candida that we're identifying as potentially playing a role in dental caries. when we look at genetics, there have been a few more papers published in the last year on genetics. We know that genetics probably account for somewhere between 30 and 60% of the influence, and certainly you've seen this patient of mine before. She only had cavities in her mandibular incisors, and that's a geographic expression of the lysyl 2 mutation of that bacteriolytic enzyme. So there are a few very distinct patterns and expressions of some genetic traits, and this happens to be one of them. They're not all quite like that. But we've identified in the past, prior to 2016, there have been 34 different genes that have identified as playing certainly a role in caries risk. This one we've had, I think we've identified matrix metalloproteinase 11 and 13 in the past, and now you can add number 20 to that list. And here's an interesting thing, and I was going to mention this a minute ago too as well. A lot of these studies come from around the world. That I look at in all of these different journals, and we find that genes may express themselves differently in different environments. So they looked at 184 4 to 7-year-old children, and looked at their decay rate and this matrix metalloproteinase number 20, and it appears to this particular MMP appears to protect against dental caries. And remember, the MMPs are found in the dentin, and those are the enzymes that break down proteins and that cause the breakdown of the dentin, particularly if you've got a lesion. So if you've got a polymorphism of this that may protect you against that from breaking down, and your own MMPs may not break down the dentin as efficiently or break down the protein, that would protect you against dental caries or progression of a lesion. But it found that it was more likely to affect one population and not another. So it seemed to favor the children that were born in Brazil, but didn't seem to favor the children born in Turkey. Now, we don't have any answer for why that was. It's obviously an environmental issue, and whether that's a dietary issue or a fluoride in the water. I mean, you can go into a lot of different cofactors there, but one of the things that we see is that a lot of these different bacteria respond differently in children than they do in adults, and there may be a different expression from some of these bacteria and their caries risk in different populations around the world, and the same with genes. So it may have a protective effect in one population on one continent and not in another. So I thought that was kind of an interesting concept. The environment plays a huge role. This study was published in this last year as well, and they took 150 10-year-olds, and of them, 55 had high caries risk, 57 were moderate caries risk, and 38 were caries free. And they compared their DMFT scores and genetically looked at vitamin D receptors. And what they found was that there was a statistical difference on this one genotype of the TAC-I between the caries active and the caries free children. So vitamin D receptors and their polymorphism may play a role in dental caries, and may be potentially a marker for this disease for patients with high caries risk as well. So one more gene that hadn't been identified before, vitamin D. This was a study that came out of Italy, 536 adults, and this really duplicated the study that was published back in 2010, where they looked at beta defensin 1, looked at at that time looked at three different genotypes for beta defensin 1, and found that the G52A had 5 times the DMFT scores of the other two polymorphisms, but that was among 300 adults. This is a study that came with 536 adults, and looking at just 2 different single nucleotide polymorphisms in the beta defensin gene. But again, the same thing supported it. So the beta defensin gene, which is a salivary enzyme, protective bacteriolytic enzyme in the saliva, having a mutation of that could increase your risk for dental caries pretty substantially. So a second study that kind of backed that up. So you know, that in my mind adds a lot of support for that particular gene. I took this, actually this is, I took this from Tirone Lodog. If you haven't seen her, she's an expert in nutrition and supplements in the United States, and she's a physician. And if you ever get an opportunity to see her, she speaks at dental meetings. If you ever get an opportunity to see her, she's an amazing speaker and a wealth of information. But one of the things I got from her was we were talking about genetics and the influence of genes and dental caries in particular, and she looked at me and said, "Kim, you know, genetics load the gun, the environment pulls the trigger." And, you know, I think that's just a great analogy. And she told it to me a few years ago, and I've carried that forward ever since. And this was a study that they looked at 77 caries-free and 77 caries, high caries risk young adults who were aged 20 to 24, and looked at their DMFT scores, and just a combination of these three genes, the carbonic anhydrase, which is another salivary enzyme, beta-defensin 1, and TAS2R38, which is a taste gene. So three genes, along with environmental factors of high levels of plaque, high lactobacillus counts, age, and low buffering capacity of the saliva. So those four environmental factors and three genes accounted for 88% of the variations in the DMFT scores. So that's a pretty profound bit of information, and I think it also, supports the thought or the concept that, you know, you've got these genes, but it's really the environment that playing a role in pulling the trigger on those genes. I can't, you know, for my patients that I suspect have a genetic risk factor for dental caries, I can't change their DNA, but what I can do is help them mitigate their environment to try and reduce their risk as much as possible. And right now we can't identify specifically, you know, different genes or risks that patients have, but I got to tell you, the more research is being done and technology that's being developed, there is coming a day when we will have the ability to do genetic testing on our patients and know who's at risk for dental caries based on their genes. So the next bunch of studies I'm going to present tonight are on just look at caries risk assessment in general. And, you know, caries risk assessment, we start with a caries risk form. This is my current form. And again, looking at those usual suspect risk factors. And the whole point of this form, we get lost in the details here as practitioners. The whole point of this form is not to find out if they're low risk, moderate risk, or high risk for dental caries. The whole point of this form is to find out why they have dental caries. Like, I'm trying to identify what their risk factors are so I can address and help manage those for the patient. I can get back to the cause of this. It's like my good friend John Coyce says, this is where you play Columbo. You know, this, you put on the coat, and, you know, the Columbo coat, and you got the dead body. Now you want to figure out who did it and what the murder weapon was, right? So the whole point of this form is not to tell you that there was a murder. It's to tell you who did it, because then, you know, then we can figure out how to solve the problem. I really, this was both a paper, an editorial paper, and an editorial that came out in the Journal of Dental Research this last year. And I think this particularly spoke to me, and I think, you know, I'm preaching to the choir here tonight, that you know, there's a few hundred people on this webinar tonight, and I literally, I applaud you all, because I'm preaching to the choir here tonight. We have an adoption curve in dentistry of somewhere around 14 years. And, you know, the adoption rates to technologies in ophthalmology are like 6 months. But in our profession, literally, you could have graduated in 1950 if you're still alive and still be practicing, doing exactly what you were trained. You can still buy the same materials and supplies and be practicing exactly the way you were in the 1950s. I've been at Canberra for 16 years now, and, you know, we've made huge progress in our profession. But for you and I, all of us, there's a lot of work. We've made huge changes in the education, you know, in the dental schools, and we're slowly making progress in the third-party payment system. But it really comes down to us to bear the burden of making this a standard of practice and educating our patients one-on-one, us and our hygienists and our assistants, every day in our practice. But the challenge that we've got is that it cannot be assumed that newly generated evidence, like I'm sharing with you tonight, however compelling, will immediately produce a significant change in clinical practice. You know, this takes time. It can, you know, the Thomas Kuhn's theory of scientific revolutions, where the old guard just has to die at some point so that this new information and these new ideas can take ground. You know, it's literally, it's slow and sporadic, and that's really been my experience with the camera in the last 16 years. It's been frustrating at times because I really would love to see more patients be able to benefit from this. And it's such, and you guys all know this, but it's such a, it's probably the most important thing that you can do in your practice and have your practice be more successful as well. But I've seen so many dental educators that I've met over the years that looked at me like this when you know, they had this frown and crossed their arms and cocked their head, and you know, they don't know, they don't want to know, and they don't want to change. And you know, fortunately, we have a wealth of good educators in our profession that do want to change and are helping our young students change now. But there's a lot of people who aren't going to change, and you know, you and I have to kind of accept that. One of the challenges that we have in dental caries is, or in camera particularly, you know, we still tend to focus on dental caries as a tooth surface level disease or a tooth level disease, when in fact we really need to look at this as a whole person level disease. And it's possible to have cross-sectional studies and look at the assessment of, you know, dental caries in our population, but at the same time, you and I need to be able to have longitudinal information on our individual patients, because that cross-sectional study is great for that generalized information or look at this disease in our population, but you and I are dealing with individual patients, and they have individual risk factors, and I want to know, when I'm sitting down with that patient, how is my treatment going to help them? Are they going to benefit 10 years from now? Like, that's where I'm looking longitudinally, because they're going to be my patient 10 years from now, and I don't want to be sitting there 10 years from now with them having a mouthful of decay around restorations that I end up placing. So it can be done, but you know, it needs to be based on high-quality longitudinal data and rigorous methodology. So we really need to just get more and more focused on dental caries as a person-level disease and those risk factors. This paper came out in Inside Dentistry. I thought it was very good. It looked at minimally invasive dentistry, which, I mean, all of those of you that know me, I mean, you know, I worked early on in the whole movement of minimally invasive dentistry back in the early 90s, and that was that led me to Canberra. You know, that was kind of my journey. That was my path to get here. And now revisiting some of those things that we thought were minimally invasive, and how when you start looking longitudinally, well, maybe that restoration, maybe if, you know, maybe a little more invasive restoration might have produced a better long-term result. And so it isn't always necessary that the least invasive is the best answer, but certainly at this point in time, we have the opportunity to take a medical model at managing dental caries. We know what the risk factors are. We can help the patient identify that and help them, you know, mitigate those risks and reduce their risk as much as we can. So we really have you and I have an opportunity right now and a responsibility to really, you know, embrace the medical model and educate our patients and educate the rest of our profession as well. This was a paper that was published in Caries Research, and looking at just occlusal caries and the biological approach for diagnosis and management. And if we look at IC-DOS, we know that from the 0 to 3 lesions, we can typically seal those, right? We don't need to do invasive procedures. We only need to start invading the tooth when they're a 4, 5, or 6 IC-DOS lesion. So it does give us the criteria. I know where the cutoff point is now. You know, we all know what that looks like. We can look at non-cavitated lesions and start assessing them, their activity, rather than, you know, sticking them with a sharp probe, you know, to see whether or not, you know, that probe sticks. Like, you know, I was taught in dental school, let's take air and magnification and light and see what it looks like, and, you know, look for radiographic evidence if there is any, and start to look at those non-cavitated lesions we can seal or treat with a very minimally invasive restoration. So how we look at and diagnose and treat occlusal lesions is certainly changing. This is a paper, the study that was done on erythritol. And erythritol has been proposed as a potential replacement for xylitol. There's a lot of science on xylitol. And looking here, this came out of Estonia, 485 3-year-olds. They treated them for a period of time with 3 times a day. They gave them 2.5 grams of erythritol. It doesn't raise your sugar index. Erythritol has less activity in the blood than, say, xylitol does. It seems to be a non-fermentable sugar alcohol as well. It seems to be, it has some advantages. I mean, it looks hopeful. The one thing that came out of this was that, with the exception of the increase in overall caries score, 3 years after cessation of the treatment period with erythritol, they still saw a benefit in terms of slowing down the development of dental caries and intervention by the dentist. So it appeared to have some long-term effects. So that's promising. Obviously, there needs to be a lot more research into erythritol. There's a couple other sugar alcohols coming up on the horizon that we may look at as well. This was a paper that came out just this month. I looked at 408 to 15-year-olds, and again, risk factors for dental caries, this may sound familiar to you, are going to include oral hygiene behavior and sugar consumption patterns. So the study highlights the need to increase awareness about oral health, and this came out of India. Now, again, we're talking about diet and bacteria. So we're looking at 8 to 15-year-olds, and typically you don't see a lot of salivary issues in patients at that age, but there is some, particularly kids that have like asthma. So again, we're looking at those generalized risk factors. This is a paper looking at using camera to predict caries risk, and found that basically it's pretty predictive, but mostly in the high or the extreme caries risk groups, not as predictive in the low or the moderate caries risk groups. And again, trying to take camera in your risk assessment form and predict somebody's risk down the road, that's not even the purpose of that form. In my mind, the purpose of that form is to figure out what's causing their caries today. That's the real value and benefit. But camera, is predictive, particularly more so in high and extreme caries risk. This is a paper that was published in December. They looked at Korean mother and children pairs, and the mother's oral health status was significantly associated with the existence of dental caries in the kids, even after adjusting for child-related variables. So again, this just all comes back to the important role that we have in terms of educating, young parents about giving them great dietary recommendations and the risk for dental caries. This it came out of Scotland, was published in November in JDR. 1,102 infants. They looked at children from 1 to 4 years of age then. They followed them 4 years longitudinally, and what they found was there was children with low birth weight and mothers who smoked had greater caries increments than those with normal birth weight and non-smoking mothers. So, and again, once more, there was no association between breastfeeding duration and childhood caries, either at the baseline or over a 4-year period of time. So, again, breastfeeding, good. I encourage every young mother to breastfeed, and it certainly has other benefits that we know of as well in terms of immunity and antibodies, what have you. But again, children with low birth weight and children that had mothers who smoked had an increased risk for dental caries. So again, that's and we know that mothers that have periodontal disease appear to be at risk for having children with low birth weight as well. This was a study of Alan Wong and his group out of University of Pacific, and looking at, again, ATP bioluminescence. They looked at 3 risk assessment groups and found a pretty strong correlation between each of the groups, between their ATP levels and as it correlated to their DMFT scores. And that's added to a number of studies that have been independently researched and studied and published. So, but I just thought I would share. There's one more for you to know. Then we look at strategies and therapies. This was the traumatic restorative technique, ART, So this is a minimally invasive, typically we're talking about spoon the decay out and just seal the tooth, or put glass ionomer in it. We may add, you may even want to add silver diamine fluoride to that equation, but this came out of Australia, but it was looking at anxiety levels. The interesting thing to me was it didn't really improve the anxiety of the patient by using an atraumatic restorative technique versus just using a needle and a drill. But it does give us another opportunity, particularly in primary teeth or for children. This was a study that it was a systematic review. They started with 450 papers. They ended up with 8. This was published in JADA back in March of last year. And they looked at caries rates of occlusal restorations with glass ionomer. And what they found was, does it reduce the incidence of recurrent lesions around that restoration margin? What they found was it didn't really have any effect on the occlusal lesion, but interproximally or smooth surfaces, it was associated significantly with better ability to prevent carious lesions. So on the occlusal surface, didn't seem to be that big a benefit, but certainly interproximally on smooth surfaces, glass ionomer is the way to go in terms of reducing recurrent lesions around restorations. And certainly I think we're probably all using that in primary teeth now. This was a Cochrane database. They looked at fluoride rinses and found that regular use of fluoride rinse by children and adolescents is associated with a reduction in dental caries, even in permanent teeth. And they're moderately certain of the size of the effect, and they pegged it right around 27%, which is kind of interesting. There were 37 trials that they looked in the systematic review. There were 15,813 children included in all of those papers. And it's interesting to me that when we look at what's the decrease in the caries rate based on water fluoridation, well, it comes in about 27% if you look at the data from the CDC. If we look at fluoride mouth rinses, it's about 27%. If we look at fluoridated toothpaste, it's like 27%. Seems to be a real common number in these studies. And I don't think we're talking plastic fantastic here, where the guy at the Bell Laboratory made up his data for like 15 years before he got caught. I think this is just the actual data, and it appears to be the influence of fluoride on the dental caries rate in a population. So I thought that just reinforced all of these other studies we've had. This was an interesting paper that was published in December, and their conclusion was food fluoridation, fluoridated milk, which is popular in some of the Scandinavian countries. We really don't have fluoridated milk here. And fluoridated water do not seem, based on the existing literature, to hold sufficient evidence for the reduction of dental caries. There is, I think, in my mind, sufficient evidence on fluoridated water, but again, most of those studies are prior to 1975, and so I think this is a question that we should all be re-examining. To be honest with our science, with our patients and the population, this is something we probably need to re-examine. Question mark, fluoridated water. I'm not an advocate to take fluoride out of the water. I live in the People's Republic of Oregon, where fluoridated water is a huge conspiracy of the government to contaminate our brains and control our minds. But having said that, I still advocate fluoride and think it belongs in the water. But I think it's worthwhile for us to re-examine that at this point in time. This paper was on prevention treatments, and at the end of the day, the best treatments that we've got early on: topical application of fluoride gel, pit and fissure sealants, and fluoride varnish. And there was a paper just published today that I saw, and it said, again, went through examining fluoride varnish, and it's one of the best forms of fluoride that we can use on patients. That was the conclusion of this paper. I didn't have time to include it in our webinar tonight. This was looking at 1,000 6 to 14-year-olds over a period of 14 days. They pre-rinsed with a fluoride rinse, and then they looked at, after the rinse, they looked before and after, looking for the amount of strep mutans that were found in the saliva. And both the rinses that had triclosan and the ones that didn't have triclosan both shown the same amount of reduction in the colony-forming units of mutant streptococci. So the fluoride rinse, again, we know has a good impact. This was a paper that looked at sugar alcohols, and again, I've been using xylitol for years. There's a lot of research that's been done on xylitol. Some positive, some that didn't turn out, as well. But again, it's sugar alcohols are certainly not cariogenic. Whether they are anti-cariogenic, we don't have enough data to be able to say that. Whether they're even cariostatic, we have weak evidence. And of all of these that are listed here, this came out of that paper, xylitol has the most evidence, but it's weak. It's weak evidence. And the rest were either inconclusive or inadequate or no evidence at all, like on lactitol. So, but I think you're going to see more research done on the different sugar alcohols. I'm still an xylitol advocate, and I'm intrigued by erythritol. This was, got FDA marketing clearance last year. Advantage of rest, it's the silver diamine fluoride that I use, and certainly it's a non-invasive procedure. I use it on children. Understanding that it's going to turn the lesion black. I mean, black. And so it's not for every population, it's not for every patient, but it certainly does give us an opportunity to arrest site-specific lesions, or at least reduce their development. And I would tell you that I'm using it in older adults as well. Patients that have dry mouth on root surfaces. So I tend to use this quite a bit. I am having mixed results, particularly with adults, but with kids it seems to be pretty consistent. So if you're not using it, I'd certainly recommend this be in your armamentarium along with fluoride varnish and sealants. So that's a good one. It gives us another paper. This was published a year ago in the California Dental Association Journal. It just gives us another tool in our toolbox, particularly for vulnerable populations. I would recommend that. So it gives us an opportunity to help try and arrest those lesions if we don't have the opportunity to treat them. Now, they've been recommended to use potassium iodide after the silver diamine fluoride. That came out of work years ago in Australia. But what I found using it myself, trying it, was it really didn't make a big difference. Those lesions are black. And even after you put the potassium iodide on it, didn't improve it that much. And even in this study, they looked at then placing a glass ionomer restoration on top of it, and really had no influence whatsoever in terms of improving the aesthetic outcome. So you can use it if you want. I didn't really see that it was a huge benefit. This is a study on probiotic milk, 261 2 to 3-year-olds over a period of 10 months, and it's pretty impressive. This came in the Journal of Dental Research back in April of this last year. And the probiotic milk, basically the kids that were drinking probiotic milk compared to like the control group and regular milk, they had basically half the new lesions. Now the thing about this is not going to eliminate the lesions, and you have to take it every day to have any benefit, but there haven't been a lot of impressive studies. The few that I've seen over the last 15 years all seem to involve milk, but coincidence or not, I don't know, but I would tell you that I was have an eye out for probiotics, looking for some impressive results or some improvement, and this was, one that was published in the last year. A lot of the results I see are negative results that are published. This was a study I included. Again, this came out in JDR back in October. It was a systematic review of 5,494 papers. They narrowed down to 33. We don't have a lot of scientific evidence to support using a toothbrush, believe it or not. But in this study, in this systematic review, the conclusions were patients who identified that they brushed infrequently were significantly at greater risk for dental caries than patients who said they brushed regularly. So it seems intuitive, but the sad thing is we don't have a lot of scientific support and evidence in that. But so this is huge because it's a huge systematic review, and I thought the results were pretty conclusive. So we can still recommend toothbrushing. I know you're all excited by that. We're getting close to being done here. This I found very interesting. This was a survey of nutrition and dietetic students, and they were given a test on their knowledge on recommendations for dental nutrition that would, be healthy and reduce risk for dental caries, and they scored very, very poorly on the exam. So the people who are giving our patients recommendations basically don't have a clue as to how their dietary recommendations influence our patients' risk for dental caries. The scores were low. So that just points out the need for us. Here's an opportunity for us to help educate other professionals about, the role that sugar plays in carbohydrates and exposure to sugar and the prolonged periods of sugar as that relates to their risk for dental caries. So I just thought that you would find that interesting. And this one is the last study I'm going to share with you tonight, and we're ending up right on time. I am so happy. This I thought was very interesting. This study looked at 109 4 to 10-year-old children, and it was a random controlled trial. It lasted for 3 months. And what they found was oral health education using a computer game was as effective as educating the families and the child one-on-one. So the education using a computer game was as effective as one-on-one communication. And I have 11 grandchildren. Computer game, their iPads and their smartphones are a high, priority, a very important part of their life, and that's how they're going to get a lot of their education. It's how the millennials get their news. It's how it's our world today, and so we can maybe leverage that. Having an educational program that can help educate kids with computers, so computer games. So anyway. I wanted to share that with you tonight. At the end of the day, this disease is all about having a healthy balance. It's a pH disease, and it's all about having a balance. I hope you enjoyed these studies. I hope you found them as interesting as I did. There wasn't any earth-shaking news this year. What it really did, it just tends to complete the picture as we see it. We're filling in the little blanks. We're reinforcing things we already knew, which give us greater confidence in that what we were thinking was right. And we're just starting to continue to, I think, to understand this disease a little better. I want to thank you all. Again, if I can ever be a resource to you, or if any, carie-free here, if we can help you, please let us know. So, Cody, we have time for probably a couple of questions.
Yes, I think so. You need some time to catch your breath.
I know. I tell you, I knew there was a lot of studies, but I'm Bill Nye, the science guy. I can't help it.
That's all right. You did pretty good. We're on time. So, yeah, let's go through a couple questions here. Is there a typical number or type of bacteria that is needed to begin the decay process? How do different antimicrobials affect different bacteria? So kind of two parts there.
Those are both really good questions. The first, is there a typical number or type of bacteria? We know that you need to have a high bacterial load, typically. But again, you've got cofactors, like if you have not enough saliva, it doesn't take much bacteria to start a lesion. I mean, you guys all see that, right, in your practices. So in a healthy mouth, where they have enough saliva, looking at those other co-risk factors, again, you've got to talk about genetics. Do they have a genetic risk factor which would decrease the amount of bacteria that would maybe be necessary to initiate lesions, and or their diet? Certainly, again, so those other three risk factors, you can't really separate them from the bacteria specifically, but we know that in general it takes 5 times 10 to the 5th levels of mutant streptococci, but 40% of our children don't have any mutant streptococci based on studies I've read. Now we're talking about a lot of studies being done on Scardovia wigsii at this point in time in different populations around the country, looking at that bacteria as a primary causative bacteria in dental caries. So is there any specific bacteria? I would say no. Our thought process is more about what the bacteria are doing rather than which ones are there. But you either need to have a high level of bacteria there, or you need to have a lot of other co-risk factors that make the person more susceptible to dental caries. How do the different antimicrobials affect the different bacteria? Well, we know that chlorhexidine is very effective against mutant streptococci, not as effective against lactobacillus. Although, Dr. Featherstone continues to recommend it and gets good results in terms of his research with chlorhexidine. Povidone iodine appears to work very well in children, but it doesn't seem to have much effect on the bacteria once they're in the adult. So I can't explain that to you. I can just tell you that Doug Young, they examined that for a long period of time at UOP, and those were the results that he shared with me. And povidone iodine is problematic. You know, I used it for 2 years of my practice. You know, it stains everything. And when you try and swab a 3-year-old's mouth with povidone iodine or get a 6-year-old to rinse with it, you're going to see it come back up on your countertops and your clothes and your floors. So that was too problematic for me, and that's when I switched to like sodium hypochlorite, which, you know, kills everything pretty much on contact, and creates a higher pH environment, which in my mind allows an opportunity for the good commensal bacteria. We create an environment, you know, for the correct bacteria to grow back, and the early adopters are the ones that grow back first. So that's how I would answer that question.
Good. Earlier in the first part of that question, you mentioned cofactors, and someone asked about saliva flow. What treatment do you recommend to help patients with decreased saliva flow or no saliva flow?
Again, and it depends on the patient. They need to understand how much risk that having a low level of saliva carries with them. Even smaller amounts of sugar then, or smaller amounts of biofilm on their teeth, dramatically increase the risk of them getting a carious lesion. So I want to make sure they're on a 5,000 part per million gel. You know, so I put them on the CTX4 gel. I want to make sure they're getting a fluoride varnish at least twice a year, preferably 4 times a year. Site specifically, I'm going to use silver diamine fluoride on lesions. You know, root surface areas that I'm worried about. You know, so I'm going to use that as site specific. I will probably, depending upon their activity level, I may have them use the treatment rinse 1 week out of every month for life. And I've got 4 patients now that I have put into trays. I've made Essex type trays and have them using a 5,000 part per million gel, you know, before they go to bed for like a half hour. You know, just trying to replace, you know, kind of retrain the biofilm that's there back into a more neutral or alkaline zone. They could even wear those trays all night, and they could wear trays at night that have no fluoride in them as well, that have nanoparticles hydroxyapatite. And that brings up another point. For the patients that don't have enough saliva, they don't have the hydroxyapatite in their saliva, and so they're a prime candidate to make sure that you've got a product with nanoparticles hydroxyapatite in their regimen. Great question, Cody.
Perfect. Well, I think that is all the time that we have tonight. So there are more questions that we didn't get a chance to get to, and we'll get to those over the next couple of days. Make sure we get a response to everybody. You'll get an email with the recording also here soon. So if there's anyone you want to send the recording to, or you want to listen to it again as well, obviously there was a ton of information that you just went over. So I'm sure people will enjoy getting to go back through it. Also, if anyone wants to schedule more of a one-on-one webinar to go over the system or any of those topics, or you know, the risk assessment type topics, implementing risk assessment in your office with us, kind of one-on-one, we're more than happy to do that as well. Just give us a call or reach out to us via email. So thanks again, everybody, for joining us tonight, and I hope everybody has an awesome night.
Yep. Thank you all so much. It's such a privilege for me to be able to share this information with you, and I really don't take for granted the amount of time that you spend listening to me. So thank you all, and have a very great week.